One, go.
Good evening, delegates and faculties member. Thank you for joining Shield Connect. And today we are back with the webinar, which is organized by Dr. Varsha Baste ma'am. And the topic is all about amniotic fluid, which is organized for all Punjab obstetric and gynecology societies. So before we start with this session, let me introduce Dr. Vidhu Mogdil ma'am. Ma'am is director and senior consultant in Suman Hospital in Ludhiana. Ma'am is obstetric gynecologist and infertility specialist, and ma'am has been awarded by various nominations on North Zone.
That's okay. That's okay. We can just fast on because the speakers are already there.
Okay, ma'am.
So we can call.
Let me also introduce Dr. Jeannie Gupta, ma'am. Ma'am is consultant obstetric and gynecologist at Healthline Hospital from Ludhiana. Ma'am has been a chief consultant and Healthline Hospital, secretary of Ludhiana Obstetric Gynecology Society, and also member of SMC and SFM and All India Women's Federation. And ma'am is working as a consultant for 15 years. So I welcome both the doctors and I hand over the session to Dr. Vidhu, ma'am. Thank you, ma'am.
Thank you so much. Welcome to all the faculties and the delegates too for this evening. And my coordinator, Dr. Guinea, you're also welcome. Hello.
Ma'am, please unmute.
Good evening, Dr. Vidhu. It's a pleasure to be here. It's such a pertinent and relevant topic which befuddles us every day.
And we have
to the land of diabetes, so polyamnios, and we also have so much oligoamnios in the term patients.
And we have two great speakers among us, so as to clarify all our doubts on this. So we first like to
before that, let me just a minute. Dr. Sehgal cannot connect, so please Haiti help her connect. She is the chairperson. Okay, over to you.
So first, we'd like to welcome our chief guest, Dr. Sushma Chawla, ma'am. Yeah. So everybody knows Dr. Sushma Chawla. She's a very senior consultant and a laparoscopic surgeon. She needs no introduction actually, but she was joint secretary of IMA Women Doctor Wing North Zone. She has many accolades to her credit. And ma'am, can we is ma'am there?
Yeah, yes, ma'am is with us.
I'm here.
And she's always charming. She gives her best. At this age also, she gives a tough competition to all of us with her agility. And we welcome you, ma'am. And then we have our guest of honor, Dr. Iqbal Singh. Sir is a senior gynecologist. He's a pioneer of IVF in Ludhiana, and he has so many accolades to his that most of the people know Ludhiana first by Dr. Iqbal. There is also all of us to take care of logs as a society. He has always been a backbone of this society. I welcome you, sir.
Thank you. Thank you.
Dr. Sushma Chawla, ma'am, would you like to say a few words?
Dr. Vidhu and Dr. Varsha, thanks for inviting me for this very important topic and a very important webinar. And that also at 8 o'clock, because by this time your OPD is finished and you can really listen to it. But whenever there is a webinar, I feel we always learn something more and more. There was a time when I go back to 1971, when I was in PGI, and that was how to see the amniotic fluid. We used to have an amnioscope. We used to peep into that to see what is the color of lighter. Now, thinking that how to find out the amniotic fluid when we are going to induce, I use, hysteroscope as a amnioscope. So every time you have something new, which I think we can share and we can do. So a lot of things to be discussed about the, oligohydramnios and polyhydramnios. So let's go on to the topic. Thank you very much for inviting me. It's a lovely topic today.
Thank you, ma'am. Dr. Iqbal, sir.
Thank you. Welcome, galaxy of intelligent and most intelligent doctors. It's a privilege to be guest of honor. And when I got the subject, I was wondering, amniotic fluid, only gynecologist talk, ruptured, non-ruptured, less or more. what else can you talk? But when I thought about it, and it's a sea of knowledge, and one life is not sufficient to know about the amniotic fluid also. I was interested how the things started, how the things happened. So I was just wondering the liquid breathing, So it has time from the ancient ages. If you study anthology and mythology, you'll find this is a god's fluid. I somehow get interested in the origin of the things. So I was very much surprised. They say we are all water. We start from the water, and we get our oxygen. And now there are things developing when we were having the liquid breathing apparatuses. You have a lung failure, they put you on a lung liquid water breathing. I won't take more time because there are so many intelligent people to say things here. But thank you everybody, and especially Dr. Vidhu and Dr. Ginny. They are the limelight of Ludhiana. They give me life many times. So thank you very much. Thank you everybody.
Thank you, sir, for facing it. I would also like to ask Dr. Varsha to speak few words, ma'am. She has been the backbone and she has been motivating us to have some topic. So this was her topic of choice. So I would like to welcome her also. And then we can start with our sessions. Varsha, ma'am.
Good evening, everybody, and I am really thankful whoever is present over here, and you have in this today's so much of working style. We are all obstetricians, so busy, and you all have made it a point to be present here. Mainly, Dr. Purlidhar Pai, today's speaker, our esteemed speaker, Dr. Kuldeep Singh, and our chief guest, Dr. Chawla Madam, and Dr. Guest of Honor, Mr. Dr. Iqbal Singh Ahuja, Dr. Jagdish Singh, Dr. Bidinder Kaur, Dr. Richa Bhargava, Dr. Preeti Jindal, and Dr. Vidul, who helped me organize this webinar in Punjab with Punjab Obituary Society, Sahil Kaur, Dinesh Pathak, Vinik Nagpal, Alka Sehgal Madam also has joined, Gini Gupta, who is the MOC, young dynamic lady, and I'm really, really happy and very, very pleased to see you all in time. And Dr. Murlidhar Pai and our speaker, Dr. Kuldeep Singh, were present before and 15 minutes before the audience. So I am really blessed with such support and guidance and so much of encouragement from encouragement.
I think there's a breaking in the. So can we invite our chairpersons for the first session? So Dr. Surjit Kaur, ma'am is the senior gynecologist and obstetrician and laparoscopic surgeon. She is the president of Jalandhar Obstetrics and Gynae Society and vice president of ISAR Punjab chapter. Past chapter secretary, Jalandhar Menopausal Society. Welcome you, ma'am. Dr. Vineet Nagpal is a senior gynecologist with Punjab government. Present designate assistant director, Department of Health and Family Welfare, Punjab. Maternal and child health, PCPND3, family welfare, ART and surrogacy clinics. Ma'am has experience of 24 years. She's been expert member Punjab State Supervisory Board, and she has number of accolades to her. Welcome you, ma'am. And Dr. Rimi Singla, she's a senior obstetrician and she's a director of Radiance Hospital and Test Tube Baby Center. She has been organizing secretary of Verticon 2017-18, president of Mohali Obstetrics and Gynae Society, and joint secretary ISAR Chandigarh. Among the pioneers in the region to develop cosmetic gynecology. Welcome you, ma'am. Dr. Gitanjali is here? I don't think so. Ma'am is not here.
I think Gitanjali is in the OT. She will come soon.
Okay. So we will now invite our speaker, and I would just take Dr. Surjit, ma'am. Dr. Vineet Nagpal, ma'am.
Yes, Dr. Vidhu, how are you?
Good, good. Dr. Vineet, can you introduce Dr. Muralidhar?
Sure. I will do that.
Yeah.
Professor Dr. Muralidhar V. Pai He is he's dean with Sikkim Manipal Institute of Medical Sciences and professor in Obs and Gynae there. And he has pretty good 35 plus years of academics, 20 awards, 15 international fellowships, and 200 plus. Oh, that's marvelous. That marvelous CV, sir.
Marvelous.
200 plus publications, 2 textbooks, and more than 700 plus guest lectures. So I'm honored to, introduce this speaker to this August gathering. And I think we can start with the session. Let's listen to this,
Yes.
wonderful guys. Yeah.
Okay. Thank you, Dr. Vineet and Dr. Vidhu. And before I start, I would like to thank Dr. Varsha, who has always considered me for all her webinars. So let me straight away go into the webinar without wasting the time.
So you are the superstar in women's conference, sir, today.
Thank you. Thank you very much, ma'am.
Yeah.
So kind of you. Yeah. So I'll be definitely talking about etiology, diagnosis, and management. And as Dr. Iqbal sir said, yes, water is the life. We thought air was life, but in our intrauterine life, air is mixed in the water and we have to breathe through that itself. So water around us is so important in our intrauterine life, but it has to be in adequate quantity, else it will not be good for us. Anything for that matter in life, the optimum is always the best. What is polyhydramnios? Obviously, it is excessive volume of amniotic fluid. Very simple. But what is excessive is to be defined. Clinically, when we measure the symphysiofundal height, and if it is more than 3 centimeters than the period of gestation, we can start thinking of polyhydramnios. We don't have to wait for the over distension of the abdomen, where the uterus is up to the xiphisternum and flanks are full. Ultrasonically, there are 2 ways of looking at it. One is amniotic fluid index, popularly known as AFI, if it is equal to or more than 24 centimeters. The other way of looking at it is single deep pocket. Dr. Kuldeep calls it MVP, that is maximum vertical pocket. MVP reminds me of Muralidhar V pi, so I take SDP. If it is equal to or more than 8 centimeters, then we say it is polyhydramnios. What is the incidence? Thankfully, it is not so high. In general population, it is 1 to 2% only. It reported differently in different places, and they are influenced by gestational age. If you happen to measure it in the preterm situation, obviously the Likert will be slightly higher, but in a post-term situation, it will be slightly lesser. Population studied also matters, whether it is low risk or high risk for polyhydramnios. Screening or indicated ultrasound. If you are doing a general screening, you may not come across many of them, but if it's an indicated ultrasound, obviously the incidence is high. And then, of course, whether you're doing it antepartum or intrapartum. Intrapartum, obviously, the Likert may be slightly lesser, especially if there has been early rupture of or pre-labor rupture of membranes. And then, this is a very interesting finding. The diagnostic criteria matters. The use of SDP, that is single deep pocket, or AFI. How does it matter? If you use SDP, then you overdiagnose polyhydramnios, as per this particular article. Because if you are measuring only one pocket, which is single deepest, by chance, in that particular area, it may be more than 8. In other places, it may not be so. So that's why there is a tendency to overdiagnose. Whereas if you used AFI, then you overdiagnose oligohydramnios, because AFI, you do it in 4 pockets. And in each pocket, you expect a little bit of Likert. It may not be there uniformly distributed. So you tend to diagnose more of oligohydramnios. This is very, very interesting, and it has to be kept in mind. Which diagnostic criteria you use to diagnose? What is the pathogenesis of polyhydramnios? All of us know the contribution to the liquor around the baby. Obviously, it's a demand and supply, and the utilization or the evacuation of the water. Amniotic fluid volume reflects the balance between fluid production and movement of the fluid out of amniotic sac. Most common mechanisms are decreased fetal swallowing. If the baby, for any reason, whether there is a neurological issue with the baby or if there's a mechanical obstruction in the esophagus or down the line, if there's a decreased swallowing, obviously the liquor will be more. Increased urination. One is decreased swallowing, other one is increased urination for whatever reason, again due to hormonal changes in the baby or other reasons, then there will be increased liquor. The homeostatic mechanisms, that is intramembranous absorption, transfer of amniotic fluid across the amnion into the fetal circulation bag. This basically works to maintain the amniotic fluid volume, the homeostatic mechanisms. More successful in preventing poly rather than oligohydramnios. That means a proper transfer of the amniotic fluid will obviously prevents polyhydramnios. What are the conditions with polyhydramnios? This is pretty much known to all of us. The first and foremost is idiopathic. That is 40%. But if these patients, if you followed after birth, you will find abnormality in 25% of them, which means actually you can see in almost around, let's say, 10% of the so-called idiopathic are not really idiopathic. There will be some abnormality. Fetal structural anomaly that impedes swallowing. In the previous slide, we saw the main contribution to the polyhydramnios because of decreased swallowing or increased urination. So here, as I mentioned earlier, the structure anomaly that impedes swallowing contributes 30% of singleton pregnancies. This could be primary GI obstruction, for example, esophageal or duodenal atresia. Secondary GI obstruction, that is congenital diaphragmatic hernia. That means it is the primary cause is not within the GI, it is outside GI, but it will have an impact on the absorption or obstruction. Cervical or thoracic mass. Again, it will have a pressure on the esophagus. Then craniofacial abnormalities like cleft palate, cleft lip, facial tumors, example, oropharyngeal teratoma or micrognanthia. All these things will impede swallowing, and this contributes to around 30% of the polyhydramnios in singleton pregnancies. Fetal neuromuscular disorders that impede swallowing. As I told you, it's not only the obstructions that will impede the swallowing, the neuromuscular disorders also will do the same thing. Myotonic dystrophy, for example, and anencephaly. Of course, nowadays, if you diagnose anencephaly, we will not allow it to continue, and we won't see polyhydramnios due to anencephaly anymore. Genetic syndromes, aneuploidy, Prader-Willi syndrome, Bartter syndrome, Beckwith-Wiedemann syndrome, and rasopathies. Please don't ask me about all these syndromes. I hope Dr. Kuldeep will talk more about these syndromes. But anyway, if you are a fetal medicine specialist, you will be thorough with all these kind of syndromes. But the point is, you will diagnose polyhydramnios first, and then you will look for these genetic syndromes to counsel the patient whether to go ahead with the pregnancy or whether to terminate the pregnancy. High fetal cardiac output state. So other than the swallowing, now the excessive urination also matters, I told you. And we all know excessive urination is because of excessive renal perfusion, and that in turn can be traced back to high fetal cardiac output state. It could be due to supraventricular tachycardia or severe anemia, as seen in case of autoimmunization, viral infections, especially parvovirus B19 and cytomegalovirus, and hemoglobinopathies. Fetal or placental mass with arteriovenous shunt, example, sacrococcygeal teratoma, large chorioangiomas, where there are arteriovenous shunts, they will also have a high fetal cardiac output state. Then the notorious, I would say, twin-to-twin transfusion syndrome, and the commonest cause that all of us first think of whenever there's a case of polyhydramnios is maternal diabetes mellitus with especially macrosomia, but it varies from 8 to 20%. In the next slide, you will see why it should vary, why it is not constant. And finally, hydrops fetalis is one of the commonest causes of polyhydramnios. I was telling about the difference in the incidence of polyhydramnios in different types of diabetes, and here it is. The rate varied by the type of diabetes. If it is GDM A1 type, where the fasting is less than 105, it is 5.4. Whereas if it is A2, where the fasting is more than 105, it is 13.4. And if it is type 2 diabetes, 15.3. And if it is type 1 diabetes, 21.2%. That's how it varies from somewhere between 8 to 22%. All of these were higher when diagnosed by SDP. Right in the beginning, I told you, if our diagnostic criteria is SDP, we tend to overdiagnose. And obviously here again, if it is through SDP, you will have a higher incidence. Fetal hyperglycemia-induced polyuria. The reason why diabetes will have polyhydramnios is through polyuria. All of us know in diabetes there is polyuria because when the sugar is lost through the urine, it will drag along water with it, isn't it? So there is osmotic diuresis. That's the reason why there will be polyhydramnios. Polyhydramnios is often associated with high HbA1c levels and fetal macrosomia. Decreased fetal swallowing or imbalance in water movement between the maternal and fetal compartments in diabetic pregnancy is an additional reason for polyhydramnios in diabetes. Let us look at the connection between aneuploidy and polyhydramnios. It's an uncommon cause of polyhydramnios. However, the combination of FGR and polyhydramnios is suggestive of trisomy 18. Here is a peculiar region. Usually, we tend to think that whenever there is FGR, there has to be decreased LICA. Now, that is true with a late onset FGR or FGR due to extraneous factors like decreased placental perfusion. But here, the cause of FGR is intrinsic, that is within the baby. For example, an aneuploidy, trisomy 18. In these situations, you will get a peculiar combination of FGR with polyhydramnios. So we have to come out of the frame of mind that FGR always means oligohydramnios. No. The combination of FGR and polyhydramnios straight away points towards trisomy 18, that is Edwards syndrome. Excess amniotic fluid is related to difficulty in swallowing. Whatever may be the syndrome or the cause, ultimately it is either not swallowing or excessive urination. That's the thing. Or intestinal abnormalities. The other aneuploidy, the famous or the one which we always look for is trisomy 21, and that is Down syndrome. It's likely related to cases with duodenal atresia. We all know that there are different markers of Down syndrome, and one of them is duodenal atresia. And that is the reason for polyhydramnias in Down syndrome. What are the clinical symptoms? This is again not a very difficult one to think of. Mild increase in amniotic fluid volume is usually asymptomatic. Patient may not realize, doctor also will not look for it. However, persistent shortness of breath, uterine irritability and contractions and abdominal discomfort can occur with severe uterine distension. If the polyhydramnios increases, all these things will be complained by the patient. Symptoms may be related to mechanical factors from a very large uterus and to high amniotic fluid pressure. This is purely mechanical. How do we classify? All the three, ACOG, ACR, and SMFM, they have used this. If you go by single deepest pocket, anywhere between 8 to 11.9 is mild. In amniotic fluid index methodology, it is 24 and more, I told you, and up to 29.9. Moderate is 12 to 15.9. Just 4. It's a box of 4 each. Here you can see first 4, 8 to 12, and 12 to 16 in a way, 4. And whereas in the lower one, you are seeing initially 6, a box of 6, and then it is 5, 30 to 34.9. The severe is anything more than 16 centimeters single deepest pocket. And if you go by amniotic fluid index, it is more than 35 centimeters or 36 centimeters, which is almost like up to xiphisternum. That's how we remember. If the uterus has gone up to xiphisternum and if the flanks are full, it's an over-distended uterus. But in terms of amniotic fluid index, easy to remember, anything more than 35 centimeters. Okay, we have diagnosed polyhydramnias, but have we solved the problem? No. Just diagnosing polyhydramnias is not enough. That's just a part of the story. Ideally, we must evaluate the cause of polyhydramnias. That is much more important, and the treatment is directed towards that. The plan is directed towards that. For non-hydropic singleton and dichorionic twins, which is almost like singleton pregnancies, 2 different sacs they are in, there's no chance of twin-to-twin transfusion here. So a detailed medical history to evaluate the heritable diseases associated with polyhydramnias, such as alpha thalassemia, IEM, G6PD deficiency, all these things should be asked for. You have to evaluate for fetal hydrops, that is non-immune or immune, though we are starting with the non-hydrop singleton pregnancies, still there can be a case of non-immune and immune hydrops. We have to evaluate for fetal anomalies. 80% of anomalous infants were detected prenatally. Anomalies often missed included esophageal atresia with a tracheoesophageal fistula, cardiac septal defects, and cleft palate. Nowadays, it is very difficult for a fetal medicine specialist to miss all these anomalies with a high resolution ultrasound. It is always better to refer these cases to a fetal medicine center, like something like that of Kuldeep Singh. Measure MCA PSV. As I told you, anemia is one of the causes of polyhydramnias through high cardiac output. So it is important for us to measure the middle cerebral artery PSV. If it is more than 1.5 mom, that is multiples of median, workup for immune and non-immune causes of fetal anemia should be done. Offer genetic counseling and fetal genetic studies. This will be routinely offered by a fetal medicine specialist, and that would include amniocentesis for fetal microarray in pregnancies with a congenital anomaly or severe polyhydramnias. Screen for diabetes mellitus. That is the minimum that we have to do. TORCH is an unlikely cause of isolated polyhydramnias, and we do not do it now to screen for it. The outcome. Many idiopathic cases resolve spontaneously if the cause is not a very big anomaly in the fetus. and especially if it is mild. However, polyhydramnios has been associated with an increased risk of several adverse outcomes in addition to poor outcomes that are related to the associated fetal morphologic abnormalities. What it means is that the polyhydramnios as such may not cause much problem to the fetus. It may cause mechanical problems to the mother, but the poor outcome is directly related to the problem that the baby had, which gave rise to polyhydramnios. That means the baby's anomaly, baby's malformation. That is the cause of poor outcome rather than the polyhydramnios per se. In other words, polyhydramnios is a manifestation of a problem within the fetus. So that is why the outcome is bad primarily. Then, of course, if there is premature rupture of membranes and early ruptures in the labor, then there can be cord prolapse and so many other things that can happen. That is another story. Maternal respiratory compromise, that is obviously because of mechanical pressure on the diaphragm. Pre-labor rupture of membranes, as I was just mentioning, these are the mechanical problems. And along with that, if there is a cord prolapse, that will be a problem. Preterm labor and by birth itself, though it is not directly related to the baby as such, baby's anomalies, but it is again a problem. If there is a preterm birth, there will be a whole lot of problems due to prematurity, in addition to the baby having problems. Fetal malposition, when there is a lot of liquor, baby tends to just keep on doing somersault movements. Sometimes it will become breech, sometimes it will become transverse lie, and that itself has its own problems. Macrosomia, again, this is not due to polyhydramnios, rather it is due to the same cause which gave rise to polyhydramnios, that is diabetes, and that will pose additional problem in terms of shoulder dystocia and others. Umbilical cord prolapse, this I already told you, when there is gush of fluid in a high pressure polyhydramnios situation, and if the cord is somewhere near the os, it will definitely come out if the head is not engaged or fixed. These complications increase the risk of cesarean birth and admission to NICU, obviously. What are the prognosis for fetal and the newborn? Obviously, the PPROM, preterm labor and preterm birth. Preterm birth is in affected pregnancies also may be the cause of iatrogenic interventions. And overall risk for fetal death and neonatal death appears to be increased due to all these reasons. Preterm birth itself is a high risk, whether there was polyhydramnios or not, the problem will be more. What is the risk of death? The relative risk increases with increasing severity of polyhydramnios. The absolute risk depends upon the etiology. I am telling again and again that the cause of polyhydramnios is the issue, and that is the one which gives rise to all problems to the fetus, including death. So the absolute risk depends upon etiology. For example, combination of FGR and polyhydramnios has a particularly poor prognosis, including perinatal death, due to the high prevalence of fetal chromosomal and structural abnormality in this setting. So idiopathic polyhydramnios associated with an increased risk of neonatal morbidity at term, because as I said, after birth, you can see, though it was idiopathic before delivery, after delivery, you can identify fetal problems in 25% of them, which I told you right in the beginning, especially neonatal respiratory morbidity. And these and other adverse sequelae are likely related to underlying etiologies such as malformations, genetic syndromes, and neurologic disorders that were not identified before birth. Now, whatever it is, how to manage? There are two issues. One is management of polyhydramnios to alleviate the mechanical problems that is happening with the mother. And then because of the baby etiological reasons, how to handle that situation. In singleton pregnancies, polyhydramnios with an identifiable etiology The specific underlying etiology should guide the antepartum fetal and maternal surveillance. Suppose the identifiable cause is diabetes, then the entire management will be surveillance for diabetes, managing the diabetes, etc. Similarly, if the cause is found in the fetus, let's say there's a hydrops fetalis or RHS immunization or whatever it is, the surveillance is towards that. In other words, you are monitoring polyhydramnios all right, but you are surveying the cause of it, whether it is in the mother or whether it's in the fetus, and that will guide our antenatal, intrapartum management and timing of the birth. For patients with severe symptomatic polyhydramnios, management of maternal symptoms is similar to that for the patients with idiopathic. It doesn't change. So it depends upon gestational age, severity, and presence of symptoms. All patients, one thing is common, antepartum fetal monitoring. That is the most important thing, whether it is polyhydramnios, oligohydramnios, or any other problem. For mild to moderate, which I have already told you, say 16, anything more than 16 is severe, isn't it? Similarly, anything less than 35 is mild to moderate. For these, you can use upon diagnosis and then every 1 to 2 weeks until 37 weeks, and then weekly for 37 to 34 weeks. That is the antepartum fetal monitoring. For severe, you have to do every week BPP for from diagnosis until the birth. For asymptomatic, non-severe polyhydramnios, intervention to reduce amniotic fluid is not indicated because it's an unnecessary intervention. Don't think that amnio reduction is an easy job in the first place. That will have its own problems. As pregnancy outcome may not be adversely affected by these mild cases, and there are no interventions that improve pregnancy outcome anyway. So if there is a severe polyhydramnios on the other hand, we have to ask first, does the patient meet criteria for amnio reduction? That is severe shortness of breath and or severe abdominal discomfort with or without uterine irritability. If the answer is yes, then you have to perform amnio reduction, that is decompression of amniocentesis, administer a course of betamethasone per standard guidelines because there is a chance that she may get into preterm labor, and treat uterine irritability by tocolytics if the contractions are present. So if the adequate resolution of symptoms happens, thereafterwards you can go for expected management. On the other hand, if there are no clear-cut criteria for amnio reduction, that's why I put green color, then you have to ask a question, does the patient have preterm labor? There may not be any maternal distress, but has she gone into preterm labor? Now, if the answer for this is yes, then we have to manage the preterm labor by whatever means, that is maybe tocolytics and other things. Whereas if the answer is no, then it is simple expected management. On the other side, let's say initially the symptoms resolved after amnio reduction, but then it again picks up because amniotic fluid is not a stagnant water that you removed. It keeps getting filled up as the baby stops swallowing or increases the urination. It becomes a refractory situation for the mother. Then you have to think of delivering her. If she's less than 34 weeks, maybe you need to wait for some more time for maybe for a steroid prophylaxis. You can repeat amnio reduction. And if she's less than 32 weeks, then you have to definitely consider a short course of indomethacin for tocolysis purpose and amniotic fluid reducing effects, both. On the other hand, if she's more than 34 weeks, then what are you waiting for? Discuss the options of preterm delivery for relief of symptoms in a situation or in a setup where you have a very good NICU. Now, most of them are able to handle successfully 34-week baby. Amnio reduction, there is no consensus about how much amniotic fluid to be removed in a given setting, how rapidly it should be removed. and whether to use tocolytics and antibiotics before doing this. A reasonable guideline is to remove not more than 2 to 2.5 liters at given time. Otherwise, there's a danger of abruptio placenta if you suddenly remove more than that. And it should be removed very slowly, no faster than 1000 ml over 20 minutes, although rates of 100 to 125 ml per minute have been reported. Better to go slowly. And initiate indomethacin, that is a tocolytic, that will also have an effect of reducing the amniotic fluid, and it will also reduce the uterine contractions. Antibiotics, of course, have to be given, single dose antibiotics. The complications of amnion reduction, as I said, the most common is preterm labor, preterm rupture of membranes, and less common are abruption if you do fast and remove a lot of them, and intraamniotic infection. That's why I suggested to use an antibiotics, and hyperproteinemia, because amniotic fluid after all contains the proteins as well. How do you follow up? Monitor amniotic fluid volume every 1 to 3 weeks, as indicated by the progression and severity of the amniotic fluid reaccumulation process. Sometimes we may do twice a week, and sometimes we do every day and twice a day, especially if it is going towards oligohydramnios. Repeat procedures can be performed at any interval on an average 2 at least 1 week apart are needed to reduce amniotic fluid chronically, especially if you're dealing with a very early gestation and you are not ready to deliver them. Indomethacin, I have to talk about it a couple of slides. SMFM does not recommend administering indomethacin for the sole indication of reducing amniotic fluid. That's what I said. It is not to reduce the amniotic fluid. You are doing anyway mechanical amnio reduction, but it is used as a tocolytic with an added advantage of reducing the amniotic fluid, not for the sole purpose. And it doesn't have any cardiac effects on the mother. In fact, this is the one that is prescribed in cardiac disease, mother having cardiac disease and polyhydramnios. However, in pregnancies less than 32 weeks of gestation with preterm labor or uterine irritability, a short course, how short is short? 48 hours of indomethacin for its combined effects, as I said again and again, tocolysis and reduction of AFI may be used. So what are the adverse effects of it, if at all? The concerns when the drug is used for more than 3 days, that's why it is advised less than 48 hours. And when it is used beyond 32 weeks, premature closure of ductus arteriosus, renal impairment in the baby. It may simulate fetal secretion of arginine vasopressin and facilitate vasopressin-induced renal antidiuretic responses. That's why it reduces the amniotic fluid. And it will further damage the renal blood flow, reduce the blood flow, and reducing fetal urine. They also may impair production of or enhance the absorption of lung liquid. So it cannot be used for more than 48 hours. The dosing is 25 milligrams orally 4 times daily, and limiting treatment to pregnancies less than 32 weeks and for a short course of 48 hours only. Maternal side effects: nausea, vomiting, esophageal reflux, gastritis, platelet dysfunction, altercations in the maternal cardiovascular physiology are minimal. That's exactly why this is a preferred drug. What is the place of delivery? Delivery at a tertiary center is recommended for patients with severe idiopathic polyhydramnios because you may anticipate fetal anomalies in 25% of them after delivery. That's why, and you should not panic. That's why they should be handled in a tertiary care center, since clinically important fetal abnormalities may not have been identified prenatally. Use of uterotonics for induction, can we use or not, is a big question. Although there is no absolute contraindication to use oxytocin or prostaglandin, these drugs should be used with caution because there's a marked increase in incidence of PPH. It sounds paradoxical, yes, but the uterus has been stretched so much. Even if you use oxytocin prostaglandins, there can be still atonicity and there can be PPH, so it should not be used in a way. Use of uterine stimulants may increase the risk of both PPH and amniotic fluid embolism. So that's why it is a controversy. Timing of delivery is influenced by underlying etiology and severity. If it's a fetal etiology, maybe sometimes you will deliver early. And if it is very severe, also you may deliver early. Mild to moderate and normal BPPs. So it is advisable to do BPP weekly or sometimes twice weekly. Induced labor at 39 plus 0 or 40 plus 0 weeks, as the risk of fetal death appears to increase significantly at term. So there is no point in going beyond term in polyhydramnios cases. 39 weeks because the incidence of RDS is very low after 39 weeks. ACOG also recommends birth at 39 to 40 weeks interval. And SMFM has opined that labor should be allowed to occur spontaneously at term with mild idiopathic polyhydramnios. Severe polyhydramnios, of course, you have to offer induction at 37 weeks to minimize the risk of umbilical cord prolapse and or abruption in the event of spontaneous PPROM. Offer earlier delivery on a case-to-case basis in patients between 34 and 37 weeks whose symptoms are intolerable and who have not responded to amnioreduction procedures. So it's very clear. In mild cases, you can go up to 39 weeks. Other cases, moderate cases, you can go up to 37. But severe cases, you have to deliver once the lung maturity is assured after 34 weeks in the interest of the mother as well as the baby. Labor management, spontaneous rupture of membranes can cause sudden severe uterine decompression with risk of cord prolapse and abruption. That has to be kept in mind. So a controlled AROM, PROM can be done. Prophylactic gradual abdominal and transcervical amnioreduction with a needle when the head is engaged. I would like to underline this word, when the head is engaged, may prevent these complications. Check fetal position frequently to confirm maintenance of cephalic presentation. Suddenly it can change, after you have ruptured the membranes, then you will be in real trouble. The fetal heart rate is monitored continuously as these pregnancies are increased risk of abnormalities. There's marked increase in the incidence of PPH. As I told you earlier, it has to be kept in mind, and you have to always give prophylactic, oxytocin or active management of third stage of labor. Thank you very much for your patient listening and the opportunity.
Thank you. Hello. Thank you so much, Dr. Pai. I think you have so beautifully covered this topic that you have made it look so easy. Though it is a difficult one, you have made it look so easy and really a very, very comprehensive, awesome talk, sir. And there were one or two questions, I think, but with the passage of time, you have, covered them all. And one comment and one question. Can I ask?
Please, ma'am.
Yeah, Dr. Vidhu, am I allowed?
Yeah.
Yeah. One is amnioreduction. I think sir has very categorically said that no, there are very, very specific indications for doing amnioreduction, and we have to really stick to that because our aim ultimately is to do no harm.
Yes.
So very, very, you have to be, correct me if I'm wrong, Dr. Pai. Hello?
Yeah.
Yeah, so
Yes.
you have to be very, very careful about the specific indications
Yes.
that do no harm to the patient by doing unnecessary amnioreductions. And
Exactly.
one question, Dr. Pai, and to the house too. You have said that in cases of mild to moderate, we can, the ACOG recommends that we can terminate the pregnancy even up till, we can go up till 40 plus 6 weeks. So
Yeah,
I would really like to know, we don't have the, we don't have the heart to wait.
Yeah. No, that's why you should refer to the first line. First line said 39 to 40, and at that time I told it is better not to go beyond term.
Yeah, so I think 39 weeks.
So
is
somehow ACOGs, those people are very bold, and they are bold to handle the litigations also. We are not that bold anyway.
They go with the normal cases up till 42 weeks and whatnot.
Exactly. That's what I said.
So,
put it
but
in a milder way.
with our setup, I think we should. This is a carry home message that we should not go beyond 40 weeks, and
I have
39
told
weeks is
that,
a reasonable
and
time to go for
I
it.
agree with you again.
Thank you. So the question is again, answered. Thank you.
Yeah,
Thank
you
you
very
so much.
Yes.
And the house is now open to questions. If there are, please.
We can take
Can
the
I just
questions
make a
later.
comment?
Okay.
Can I make a comment?
Yeah,
Dr.
yeah.
Alka
Sure,
here?
ma'am. Sure. Good evening,
Yeah.
ma'am. Kaise ho?
Yeah, बढ़िया. I wanted to ask Dr. Pai. Dr. Pai, you said that if the head is not engaged, you should not be inducing. That's what, have I caught you right?
Okay, let me correct myself, ma'am. Good evening.
Yeah.
See, the only point and the reason for that kind of a statement is that, let's say head is not fixed or even engaged, and you go ahead and do a PROM and you have not been careful, and the gush of blood comes because of increased intrauterine pressure, and cord may come from somewhere and cord prolapse can happen.
Yeah,
So
I just wanted to add here something.
Yes, yeah.
You know,
So
in the
that's
past, we
why
used to
what we do
do.
is usually when we do the PRM, you put two fingers there and put in between, and we do what is called controlled ARM.
ARM.
And don't
Yeah.
release the fluid, and this may help the head to descend down and get fixed also. So, but that has to be done carefully.
Yeah, that's what I was just coming to, that it was a past. In the past, we used to very often be doing stabilizing induction.
Correct.
We used to do something like that. And similarly,
Yes.
if you just know that the lie is correct, the cephalic, it's not engagement, but the lie is correct, you know that it will get in, then you can even do a slow amniocentesis followed by induction and allow this thing. The only purpose is that
I
it will
agree.
be a
So
slow process. And
because as we all now know that we cannot use oxytocin unless we have done a ARM. So we should not be doing oxytocin induction just like that. And simply putting misoprostol and other things may be sometimes dangerous with a large uterus there. So I totally agree with you, madam. There a controlled sort of rupture of membranes and has to be done very carefully by a preferably experienced person, and then it would be good.
Another possibility is that if you do a PV examination and you find that the cervix is also, if the head is not got engaged, cervix is also unlikely to be effaced. So another possibility is to put in a follis and then do an amniocentesis, let the head come down and remove the follis. So what I was trying to say is that with the ultrasound and with the possibility of abdominal centesis nowadays, and with follies and so many things, you can, individualize the management depending upon what your findings are.
Thank you, ma'am. Thank you for your inputs.
There's a request in the house for a video of amnio reduction if you have.
Unfortunately, I have not, incorporated that. Maybe some other time. It may be available.
That's not very difficult also. It's not very difficult
sorry,
to do.
this was in the chat box, so I
know, I understand. So, So what you do is you put an amniotic and then connect it to a IV fluid kind of a thing and put a bottle down there, and it will slowly get it done. You don't have to actively. You don't have to actively, pump it out.
Thank you so much, sir. Thank you.
Yeah.
Thank you, Dr. Vidhu, Dr. Gini Gupta, and Dr. Varsha, of course, for this opportunity. Thank you.
Very informative and to the point presentation, and we really had a good learning. So, Dr. Gini, can we start the second session?
Yes, Dr. Vidhu, that was a lovely first talk, and I have the privilege of welcoming my wonderful panel. They are all the professors of our mainstream medical colleges in the North. Dr. Alka, a teacher to me also, she's professor and head department of OB-GYN Sector 32 with hundreds of publications. When I see her name, I think of genetics and how she has painstakingly, knock, and pushed into our heads so many concepts which we were so confused with. She is on the board of numerous journals, national and international, and antenatal diagnosis in the first trimester, not only of aneuploidy, but other chromosomal anomalies and thalassemias. It has been made so easy, approachable by none other than her. She was also a visiting professor to universities in Australia, Japan, China, and has so many awards that I will not bore you with the list. But welcome, ma'am. It's a pleasure always to listen to you. Then we have our own professor and head of my own city, the charming Dr. Ashima, who is always there, soft spoken, intelligent, and a brilliant, brilliant professor who has chaired so many sessions, taught so many students, and has number of publications. She is always ready to take whatever referral we send to her and solves it with all the dexterity that she has. And then I welcome Dr. Parneet, who is from the Patiala, the professor and head of OBG, GMC Patiala. Teaching experience of 21 years. We have a formidable panel today. Examiner for UGs and PGs for more than a decade, and so many publications and written chapters. And so it's a befitting panel for our main speaker. That is Dr. Kuldeep, the trainer of trainers, I would say. Sir, more than a decade, I am seeing you in all our main gynecology meetings, and your passion for teaching, your humbleness, and your willingness to answer sometimes at odd times. It's amazing. In a day and age when teaching and teachers are dwindling, you are a gem in this galaxy of faculty. He's practicing ultrasound in Delhi, and he has more than 300 talks all over the world, globally. So many, more than 4 awards and gold medals in the field of ultrasound. His books are translated into international languages. Sir was awarded the Imaging Science Award at AICOG in Delhi, and his Sono school is running, on most of our telephones, and he is also going to be launching in his latest venture, We Question, You Answer. Here, we welcome you, sir, on this lovely 1st February evening. He is a visitor commonly to our city, and we always await you eagerly. His topic is ultrasound monitoring of amniotic fluid during antenatal care. Sir, Dr. Kuldeep.
Thank you, Dr. Guinea. Thank you so much. I'm just going to start sharing my screen. I'd like to thank Dr. Varsha for giving me this opportunity. Seemed to be a simple topic, but as and when I just entered it and I realized it, no, but there are plenty of things. It's not just calculating fluid index. I'd like to thank Dr. Iqbal Singh sir also. I've been coming for so many years, and he's always so active and always available. Thank you, Dr. Guinea, again for such a lovely introduction, and thank you, chairpersons. We're going to start off with the ultrasound monitoring of amniotic fluid. I hope the screen is moving and you hear me and see the screen perfectly. So what we're going to be doing is I'm going to be explaining what exactly why is the amniotic fluid so important from the perspective of ultrasound as well. And it's not only that in the 3rd trimester or in the 2nd trimester, we need to be looking at it from the 1st trimester itself. Dr. Pais lovely explained so many things, so it will make my work easier. It serves multiple functions: biomechanical protection, immunological properties, hormonal regulation, and the development of plenty of organ systems and the pulmonary development as well. What we need to remember is that the evaluation of amniotic fluid is an indicator of fetal well-being. And the best way to do nowadays, rapid, non-invasive, we have ultrasound at our help. It's a safe, real-time option, and we have comparable clinical outcomes. We can do an assessment, we can do a measurement qualitatively or in a semi-quantitative method as well. So we have the deepest vertical pocket, the single deepest pocket, or the maximum vertical pocket, whatever you need to name it as, or we have the 4-quadrant amniotic fluid index. And I still get so many reports where I see the pictures and it's not being measured correctly. So we need to be very watchful, and I'm going to be explaining a few things on that. So once we start off, after 8 weeks of gestation, the fetal kidneys begin to function and they produce urine. It's not a key component till we start doing our or looking on from 20 weeks onwards. The fetal urinary production, main volume of amniotic fluid. This is all little theoretical, but I'll come on to the ultrasound pictures as well. Last 20 weeks, the fetal respiratory and gastric secretions also contribute, and the amniotic fluid is recycled primarily by fetal swallowing. This is how we need to be looking at the intramembranous pathway of the placenta. The amniotic fluid increases at a linear rate, and then towards the end, it starts to reduce. The amniotic fluid assessment, it's an integral part of the routine anatomic fetal evaluation, and the derangements can sometimes be found incidentally. The ACR guidelines state that an amniotic fluid assessment should be performed at all sonographic fetal evaluations. There are specific high-risk factors where they have a potential to alter the amniotic fluid. Primarily, we're looking at hypertension, pregnancy-induced hypertensive disorders, growth restriction, or we're looking at anatomic anomalies or late-term pregnancies. Clinically, when the fundal size on a routine examination does not correlate, well, again, a scan is asked for, or one does it on your own, and you're going to be looking at the amniotic fluid assessment over there. It helps us to rule out the rupture of membranes included in the general assessment of a fetal well-being, and it's one of the most primarily things on biophysical profile, which I'll be discussing towards the end. In the first trimester, the amniotic fluid volume, you can see, increases from 1.5 ml to 25 ml at 10 weeks, 100 ml at 13 weeks. Plenty of normograms. We are gradually getting into our 3D and 4D stuff where we can be doing our measurements as well, though still plenty of work is being done on that. In the first trimester, it can be assessed from weeks 7 to 12. The amniotic fluid index is seen in the second trimester, where you can start looking at. In the first trimester, the first and foremost is the eyeballing. So do not be in a rush to quickly go and measure. No, you need to be looking at an eyeballing of the complete pelvis has to be done, and then that's when you start taking the measurements. The amniotic fluid volume related to, but it's different than the mean sac diameter. We have a gestational sac, next to come is the yolk sac, then the embryo in the signet ring stage, and then you have an amnion around the embryo, and that starts increasing. So we're supposed to be taking a look at that. So if you're looking at a mean sac diameter, you're supposed to be measuring inner to inner, all three measurements in two different planes has to be done. The mean sac diameter is the measurement of the gestational sac, which includes the amniotic sac as well. What we need to be watchful is, are we looking at an oligoamniotic sac? That's basically the mean sac diameter minus the crown rump length less than 5 millimeters. On an eyeballing, if you see, there is crowding of the gestational sac. It's appearing as if the sac is just, the embryo is taking all the place. So you start thinking of that this could be an oligoamniotic sac. Take the mean sac diameter, subtract the crown rump length, and if it's less than 5, it's an oligoamniotic sac. Looking at various dimensions of the amniotic fluid volume, again, we do not measure it routinely, but just so that you are aware of it, the difference between the mean sac diameter or volume to the amniotic volume in the first trimester. Then when you're assessing for the anomaly scan, you're supposed to be looking at quantity, and you're supposed to be looking in for, am I seeing any amniotic band? We can do a deepest vertical pocket measurement or the amniotic fluid index. The technique is very, very important. You need to be, the patient is supine, the transducer has to be perpendicular. So let's say this is the transducer, it has to be perpendicular to the obstetric table, parallel to the midline. So for a maximum vertical pocket, first please scan the entire uterus and looking for a pocket of amniotic fluid with the greatest vertical length. Do not measure it horizontally, it has to be the vertical. Vertical calipers are used to measure the depth in either millimeters or centimeters. You could be using a single deepest pocket or a deepest vertical pocket, and it has to be at least 1 centimeter in width to be considered a valid pocket. The exception is when you're looking in for a biophysical profile, which requires a 2 centimeter pocket as such. When measuring, please be careful that you're not crossing any fetal body part. So the limbs and the umbilical cord have to be excluded, because you might be saying this is normal when you've included that and it later turns out to be oligohydramnios. Be watchful for that. For the amniotic fluid index, you're supposed to measure it in all 4 quadrants of the uterus. Again, the transducer perpendicular to the obstetric table, parallel to the midline. Take all the measurements in your machine now. In fact, everybody's machine now is going to add that up in millimeters or centimeters and let you know. So you need to divide the uterus into 4 quadrants, umbilicus as a central point. The criteria apply to the pockets obtained in each quadrant, and you can add them up. The amniotic fluid index is an estimate of the amniotic fluid volume, and it's also a part of the biophysical profile. The normal range varies with gestational age. The typical values 5 to 25 centimeters is normal, a median of 14 centimeters from 20 to 35 weeks. And after that, the amniotic fluid volume begins to reduce. If it's less than 5 centimeters, you're thinking of oligohydramnios. That is basically, it is below the 5th percentile. Some people say that if it's between 5 to 8, you can start thinking about borderline, but strictly speaking, we're taking as less than 5 centimeters. Something which is more than 250 millimeters, more than 25 centimeters is considered as polyhydramnios. That's how you're going to be dividing the uterus into 4 quadrants, keeping the transducer perpendicular to the table and parallel to the midline. Add up all the 4 pockets. Be careful whenever you need to use a color over there, so that you're sure of that you're not adding up the umbilical. Then you please do not apply too much of pressure and do not measure obliquely, because all these things are going to give you false results. You're looking at normal Leica, you're looking at oligohydramnios, polyhydramnios, and otherwise be careful of whenever you're looking at amniotic bands. Again, recommendations: hold the transducer perpendicular, identify clear boundaries, measure the largest unobstetric amniotic fluid pocket, and use color Doppler for areas where the umbilical cord is not visualized clearly. Be careful. Do not unnecessarily measure it. Switch on your color box so that you do not make a mistake. You're looking at over here, and you know that there is no point measuring here. This pocket is full of umbilical cord. Just switch on your color box and you know this is the pocket that you would be able to take in there, so that you do not make a mistake. Then when you're measuring it, be careful. Do not include the umbilical cord. Do not measure it obliquely. Do not measure it horizontally. It has to be a vertical measurement, and it has to be all the 4 pockets, and you get the amniotic fluid index. Various portions over there where you're looking at various charts. Otherwise, you can all go through your books as well, which shows you where exactly is the 50th or the 95th percentile, or between 5 to 25 centimeters, as various ages where you're looking at the 5th, the 50th, and the 95th. For a deepest vertical pocket, the depth of it's between 2 to 8 centimeters, it's normal. If it's below 2 centimeters, it's oligohydramnios, and more than 8 centimeters is polyhydramnios. The moment you're seeing something of this sort, you need to be watchful. Why is it so? And especially when you're doing your anomaly scan, you need to be watchful. If I'm looking at the general aspects, I'm looking in for, is there any abruption, any twin transfusion, any maternal symptoms we're looking at in terms of hypertension, preeclampsia, and then we need to be carefully watching out for abnormalities. The moment you're looking at abnormalities and oligohydramnios, be watchful of looking in for the renal problems. Be watchful for looking in for chromosomal abnormalities, especially triploidy. Otherwise, we have a bunch of things and we need to be doing a careful anatomic survey. If you're looking at polyhydramnios, more than 25 centimeters, first and foremost, we're going to be looking in for GI abnormalities. The higher up the obstruction, the more the polyhydramnios. The higher up it is, the earlier we're going to be picking it up. If it's a jejunal one, the polyhydramnios is also going to be less, and we're going to be catching it later. If you're looking at CNS abnormalities, which Dr. Pai just now told us in detail, you're looking at twin transfusion, or we're looking at diabetes mellitus. Then it's not only looking in for the quantity, we're looking in for inside the liquor as well. If you're looking at amniotic bands, they're seen 1 in 1200 live births. They usually just break away and you're not worried about them. But whenever you see it, be careful of mentioning it in your report and looking for any amputation defects. Any defects on the fetal face, anterior abdomen, or a limb amputation defect, mention where exactly you're looking at it, so that next time, irrespective of what stage are you looking at, you're supposed to be seeing that again and looking for the same abnormalities. Thin, floppy amniotic band. But still be watchful. We're looking at the feet over there. Be watchful. See carefully for movements. The bands are seen as thin mobile threads. They can be seen attached to or around the baby as well. The good news is that about 70% of them disappear on follow-up, either due to compression or rupture. But still 30% might give trouble. Be watchful for that. Then it's not only that you're going to be finding an anechoic liquor. There could be chances where you're looking at echogenic amniotic fluid. It can be seen in 4% of first and second trimester examinations. In the first trimester, there could be hemorrhage into the amniotic cavity. There you're looking at echoes inside the gestational sac. Large yolk sac, and you're looking in at hemorrhage inside. In the second trimester, the most common cause, vernix, or you could be having the other acrania, anencephaly sequence, and the various other things. But it's more commonly seen in the third trimester, where we tend to panic a little bit, but we need to be knowing that biophysical profile and color Doppler are there to help us. So we need to be watchful whether it could be this or could be this, and you need to be watchful before announcing. There, look at that. You can see the umbilical cord so clearly. It's an echogenic amniotic fluid. Plenty of movements, biophysical score was fine, the Dopplers are okay, but still it's like holding on to with crossed fingers. Everything will be fine once the baby is born. Then finally coming on to the role of licher amniae in biophysical profile. We have these 5 sets of things, but amniotic fluid volume, and I'll tell you how important it is. You need to be looking at what is normal. A 2 centimeter by 2 centimeter pocket is considered adequate. But if you're finding that it's absent or it's smaller in size, you know you're going to be giving it a score of 0. You're looking at a biophysical profile for 30 minutes. Again, we all have color Dopplers now, so we quickly go on to, let's see the umbilical artery flow, the middle cerebral. In fact, there are plenty of people who say it's gone redundant also, but still there's no harm, because every place, even if you're going on to the periphery, does not have color Dopplers. We need to be watchful. So we have non-stress test, fetal breathing, movements, body movements. This is all telling us about the acute phase. The amniotic fluid index is telling us about the chronic phase. We have a modified biophysical profile, which is a shortened study of the ANST and the amniotic fluid index. You're supposed to be seeing whether am I seeing a proper acceleration or not. And there's a linear relationship between the biophysical score and the umbilical cord venous pH. pH reduces, we know we're landing up into trouble. A biophysical score of 8 and 10, we're looking at normal pH levels. If we're going down to 0, we know we are in deep trouble and we need to do an immediate delivery. Now, what we're looking at is an abnormal amniotic fluid. Lower pH compared to short-term abnormalities such as an abnormal NST or fetal breathing movements. So we need to be watchfully looking at, I'll tell you, if you're looking at a score of 6 is how it's going to be telling us about how fast do we need to deliver. The diagnosis and management, they need to be taken into consideration maternal and fetal risk factors. If you're looking at a score of 6, if there is oligohydramnios, the study has to be repeated in 24 hours. You need to be even more watchful. And if the patient, it should possibly be induced if we're looking at term. But if the score is 6 and the other points, fetal movement, which is more reassuring, the study has to be repeated in a short interval. So be watchful for looking in for amniotic fluid index at this stage. Score of 2 to 4, not reassuring. Recommendation is to either move towards labor induction or cesarean, which you all must be practicing and doing it. Score of 0, we know it's impending fetal asphyxia. We have color Doppler helping us by looking at the cerebroplacental ratio, by looking at the middle cerebral artery, the ductus venosus, the umbilical artery flow, and nowadays we have the aortic isthmus also helping us. But in no way does it mean that we are not going to be using the biophysical profile. So what you need to be doing, friends, is you need to be looking at the amniotic fluid right from the first trimester itself, evaluate in the second trimester, looking in for anomalies if it's up or low, and looking at the third trimester, especially more for oligohydramnios, because that's what's going to tell us the fetal well-being. Thank you. Thank you so much.
Thank you. I think you have covered it quite well, Dr. Kuldeep. And combined with the, am I audible?
Haji, ma'am.
Yeah. And combined with what Dr. Pai said, I think it's a topic which is, usually not talked about. But I think it is an excellent choice because it's important, and it is important to know the correct method of amniotic fluid measurements and the significance of this, and combine it. Only thing which I want to add was probably that we should also correlate it with the cause of the abnormality while we take the decision for how to manage. I've very frequently seen that the indication for induction itself is oligohydramnios, which is, it's hard to accept, because if there is an oligohydramnios, there has to be some reason for that. So the only thing important for obstetricians would be to first Find out the reason for oligohydramnios before you decide how to manage it further. It should not be a direct indication. If it's a good, healthy baby, the oligohydramnios has a different significance than oligohydramnios with an IUGR. So we should keep in mind the clinical picture of the patient while deciding the management.
True, ma'am. Thank you, ma'am. Thank you.
And Dr. Kuldeep, you were talking about the color of the amniotic fluid.
Basically, the echogenic liquor. We'll not be able to tell the color, but it's just the echogenicity.
Yeah, I just wanted to ask you, can we actually differentiate hemorrhage and within the amniotic fluid versus meconium?
No, ma'am, that's extremely
No, you
difficult.
cannot.
That's extremely difficult, ma'am. Meconium is just that if it's a fresh hemorrhage, again, the problem is whether it's behind the placenta or it's in the amnion, that's another one. And it all depends on how much of a movement is happening and how's the baby. Is it any hypoxia happening over there? Any changes in the color Doppler? But that can be anybody's guess as such. And so things sometimes can really go offhand over there, ma'am.
Thank you. Any other questions from the audience?
Good evening, Dr. Alka.
Yeah. Good evening. How are you, Ruchi?
He's been my mentor on the faculty, and it's such a pleasure to meet her on screen and off screen. I just want to know, is there need to press a panic button on seeing an ecogenic amniotic fluid?
Ma'am, I'll be very honest. There were times when I used to press the panic button, and I would say out of 10 times, 3 times I used to get a shabashi, and 7 times I used to be really banged at. So the thing is, I just mention it on the phone, or if it's until it's very, very echogenic, and on top of it, I see color Doppler changes. That's when I press the panic button. Otherwise, I don't.
Okay, thank you.
Yeah, because that's I think, Dr. Kuldeep, that's very logical and scientific, because important thing is that whether we are suspecting meconium. And as I said, the clinical picture of the patient is also to be taken into consideration. It is very important when an obstetrician herself is doing the ultrasound, because you know overall picture, you know, you have many things in your mind, including the past obstetrical history. Sometimes they give a history of cesarean section for meconium. So although we know that meconium is not always a sign of distress, but then somewhere in the back of mind, if you have that clinical picture, history, or that ultrasound findings, you can suspect. In the past, we used to do amnioscopy. I don't know how many. I mean, it's completely out of context nowadays. But in the past, for some patients where you suspected amniotic fluid meconium, we used to do amnioscopy.
May I say something? Hello.
I think Dr.
Yeah,
Sushma would really appreciate that, because it was a common practice in PGI to have a look.
I remember having done amnioscopy when I was in the PGI, but now when I suspect, meconium staining, and if I have to induce and to decide whether I have to do the normal delivery or cesarean, I put the hysteroscope and use it as an amnioscope. You can directly see that whether it's meconium stain or not. It is meconium stain, then we don't induce, go ahead with the cesarean. So that is that. This is that term. Thank you so much.
Thank you, Dr. Sushma. That was an excellent way of, thinking forward. Because sometimes you do get that flakes, and then you keep wondering whether it is meconium. Could it be meconium? Could it be meconium? And it does affect, even without Doppler affected, it does alter your minds. You start thinking on the lines that if it is amniotic, am I delaying the decision making? Thank you, Dr. Sushma. That was an excellent idea.
I think with the progress in science and ultrasound, you may be able to see the color of the liquor also after some years.
Yeah,
Like
it's true.
Dr. Pradeep Singh, you can say easily. You know whether it's a meconium or it's some other hemorrhage. I think
I always feel, so there's some of the other clue that the fetus gives us, but it's not always
Yes.
correct. But
Yes.
the moment you have an index of suspicion, I always say it's good to mention it to the patient so that they're a little more aware, rather than cutting a sorry figure after 2 days or 3 days, and the patient says, if you could have told me to be a little more careful, I would have come back. And if anything of this sort is, at least we can call them back for an NST or tell the patient to be monitoring fetal movements even more carefully.
I think we need to move on to the panel, which we are all waiting for. Thank you to Dr. Kuldeep and thank you to all our professors. And now we throw open the panel discussion. It's my proud privilege to invite Dr. Varsha and Dr. Preeti. Dr. Varsha is the lady behind all of us being on this platform today. She's in Nashik since 30 years, the city we associate with the beautiful raisins that we eat. And she's director of her own Baste Multi-Maternity Center, and she has to her so many achievements. She's the founder of Cell Anti-Aging Stem Cell Center, first ICSI baby born in Northern Maharashtra, and she's past president of Obgyn Society, Nashik, chairperson of FOGSI Endoscopy Committee, and has also received the prestigious Anandibai Joshi Award, and organized many national and international conferences and has publications to her credit. Dr. Varsha, and I also have the lovely privilege of inviting a colleague today, Dr. Preeti, with whom I have worked at the Institute Chandigarh. She is MD, DNB, MRCOG, FICOG, and is a practicing obstetrician and also specialist of IVF, cosmetic gynae, high-risk pregnancy, laparoscopic and robotic surgery as well. You have so many degrees and so many, you're director of the Touch Clinic Mohali. She's the past president of the Mohali Obs and Gynae Society. And we often see you in the academics, which is going on around our state, and so many awards and international publications. So I request you both to entertain us and educate us with your lovely panel, which is so pertinent to day-to-day practice. Thank you.
Thank you, Dr. Guinea, for such a lovely and beautiful introduction. And you are so dear to me. And it's always nice to see you at these webinars. Right. So I think Dr. Varsha ma'am is busy in her CME. So I would now like to start the panel with the introduction of our esteemed panelists. I invite our first panelist, Dr. Dilpreet Kaur, again a very dear friend, and she is Professor, Department of Ops and Gynae, GMCH, Chandigarh. She is ex-consultant CMC Hospital, Ludhiana, and also she is fellow ICOG, and she has done fellowship in public health leadership and management from AIMS Jodhpur. She has lots of achievements to her credit. She is joint treasurer and executive member ISAR Chandigarh chapter. She is executive member and past treasurer Chandigarh Regional Menopausal Society. And apart from
thanks Dr. Preeti.
And apart from lots of awards, the best thing is her smiling face always and her academic bent. And whenever we ask her to come, she is so much willing to come on the webinars and help us out. Welcome, Dr. Dilpreet. Now I would like to introduce Dr. Virinder Kaur. Dr. Virinder Kaur, again a very senior gynecologist, and she did her MBBS and MD Gynae from GMC College, Patiala. She is MBBS of 1988, and that makes her 1 year senior to me, and MD in year 1998. Then she joined government job. She is working as gynecologist since 1998. She is presently head of Department of Gynae at GMSH Sector 16 Chandigarh, and they actually look after a lot of load of deliveries and obstetrics of Chandigarh. She is an experienced teacher of DNB students for past 16 years. She is experienced in lots of gynae and ops surgeries, which we all can imagine. And she has been promoted as Deputy Director of Health. So welcome, Dr. Virinder.
Thank you, Preeti.
It's so nice to see you.
Yeah, same here.
The next esteemed panelist is Dr. Seema Grover Bhatti. She is MBBS DGO MD DNB FICOG. She is working as professor and head department of obstetrics and gynecology at GS Medical College Faridkot since last 9 years. She has teaching experience of 19 years as medical faculty. She completed advanced course in medical education from MCI Nodal Center. She is member of Medical Education Unit and Ethical Committee of Medical College and also member of Clinical Research Committee of FOXY. She is recipient of prestigious FOXY CS Dawn First Prize at Agra AICOG 2016 and second prize for poster presentation at IMS conference in 2012. Welcome, Dr. Seema. Are you there?
Yes, good evening, everyone. Thanks for those kind words.
Welcome. It's lovely to have you in the panel. Our next panelist is Dr. Ruchi Bhargava. She is Director, Bhargava Advanced Gynae Surgery Cancer Center, Jalandhar. She has a work experience of more than 20 years and she has participated in CMEs and seminars at national, state and local levels. Her focus is on safe mother and healthy child and she has keen interest in high-risk pregnancy and gynae oncology. Welcome, Dr. Ruchi.
Thank you very much, Dr. Preeti.
Most welcome. And our next panelist is Dr. Dinesh Pathak. It's lovely to meet you again. We were together yesterday also in the panel. So Dr. Dinesh has graduated from Medical College, Calcutta, Calcutta University in 2000. He is postgraduate from Eden Hospital, Medical College, Calcutta, 2007. Currently working as Senior Divisional Medical Officer, Obs Gynae in Railway Hospital, Firozpur, Punjab. President, Firozpur Obstetrics and Gynecological Society. He is founder secretary of the FOX, Firozpur, Punjab. He has special interest in high-risk pregnancies and maternal mortality and minimal invasive surgery. He has published papers in national and international journals. He has contributed chapters in FOXY Focus on Recurrent Pregnancy Loss, first edition 2018. He is also winner of quiz competitions and also part of scientific sessions at national level and state level conferences. Welcome, Dr. Dinesh.
Thank you, ma'am.
Our next esteemed panelist is Dr. Mini Bedi. She is DGO DNB FMAS. She is Associate Professor, Department of Obs Gynae, Adesh Institute of Medical Sciences and Research, Bhatinda. She is a fellow and ex-registrar, Fetal Medicine Unit, Fernandez Hospital, Hyderabad. She has done fellowship in minimal access surgery from Delhi and her special interest of fetal medicine and high-risk pregnancy. Welcome, Dr. Mini. Dr. Mini, are you there? Dr. Mini is there? Somebody check. Meanwhile, we move to our next esteemed panelist, Dr. Jagjit Singh. He is consultant, PHC Ahmedgarh, Ludhiana. And he is also Chief Advisor, STA PCMS, Specialist Doctors Association, Punjab. He is Vice President, All India Federation Government Doctor Association and Founder Secretary, Faridkot Obstetrics and Gynecological Society, Faridkot. Welcome, Dr. Jagjit. Lovely to have you on this panel.
Thank you, ma'am. Thank you.
Welcome. And our another esteemed panelist is Dr. Shail Kaur. Dr. Shail Kaur, she is MBBS MD FICOG. She is professor and in charge high-risk antenatal unit at Punjab Institute of Medical Sciences, Jalandhar. She is member FOXY Medical Disorders in Pregnancy Committee. She is academic chairperson of FOXY Jalandhar, former editorial board FOXY Sexual Disorders Committee. She has publications in various national and international journals. So we have lots of esteemed and very literate panel over here. Reviewer of Journal of South Asian Federation of Obs and Gynae, Journal of Gynecology and Obstetrics. She has contributed chapters in books and she is faculty at national and international conferences. Welcome, Dr.
Thank you.
And so now we will start the panel. Shall I share my screen?
Yes, ma'am.
Right. So, So we start the panel after two very, very informative lectures, which have almost covered all the parts of this panel discussion. The main aim of this panel is basically, as we have very esteemed faculty with us, to give inputs from their own personal experience as well. So it is high time that we as Indian obstetricians make our own guidelines, and we need to use our own experience, because we are part of one of the most populous countries of the world, and, and we need to stop just blindly following what the Western world is throwing at us. And you all are very, very esteemed panelists here with a lot of experience in obstetrics. So I would really request that please feel free to share your own experiences and not just stick to the guidelines, so that we can tell our viewers what extra one can do in very difficult situations. So Dr. Varsha will join us as and when. My first question goes to Dr. Dilpreet. Dr. Dilpreet, can you please enlighten what is amniotic fluid exactly produced from?
Hi, hello, Dr. Preeti. Amniotic fluid, basically, it's transited from the maternal serum initially. So first is this thing, but later on, as the amniotic cavity develops, so it starts secreting from the transited from the fetal circulation also through the umbilical cord, through the amniotic membranes, and from the fetal surface of the placenta, and even through the fetus till the skin gets squamated. So 20 weeks, early half of pregnancy, skin is highly permeable. So it is transition from the fetus also, and fetal lung secretions. So all these, they contribute to and most important in the later on is the fetal urine. Urine production is somewhere around 400 to 1 liter in a day, daily urine output. And they say by the various things, it has been documented that around every 3 years, whole of the amniotic fluid gets replaced. So it keeps on producing all these things, and the baby keeps on swallowing and all these. So it all gets exchanged almost every 3 years.
Very rightly said, Dr. Dilpreet. So basically, amniotic fluid is in circulation on its own. Baby swallows the amniotic fluid, and then most of it baby excretes through the skin or through the urine, and that's how the circulation keeps on going of the amniotic fluid. My next question is to Dr. Virender. Dr. Virender, how does the amniotic volume increase with each trimester in pregnancy?
So as told by Dilpreet, initially it is from the transudation from maternal plasma, and right from 10 weeks to 20 weeks, it increases from 10 ml to 400 ml, 25 ml to 400 ml. And from 20 weeks onwards till term, main contributor is the fetal urine and the lung secretions. And at 18 weeks, fetus starts voiding for 7 to 1400 ml per day. And at around 28 weeks, it is around 800 ml. And maximum amniotic fluid is at around 32 to 36 weeks, which is about 1 liter. And then it starts decreasing, and at term, it is again around 800 ml. A fetal kidney at term secretes 600 to 700 ml per day urine, and 250 ml is from the respiratory secretions. Oronasal secretions also contribute to the volume, and mainly it contains carbohydrates, lipids, proteins, and lanugo, vernix, and electrolytes.
Correct. And so as the baby starts maturing, the fetus starts maturing, the different organs, they start contributing to the amniotic fluid. So Dr. Seema, how is the amniotic fluid volume controlled?
Okay, so there is amniotic fluid production going on about 500 to 1000 ml at term, and yet it has to be regulated through mechanisms, which are the one is fetal swallowing, and second thing is there is intramembranous absorption through the amnion into the fetal circulation, so that the balance is maintained. So amniotic fluid constituents already ma'am has mentioned, this urea, creatinine, uric acid, desquamated cells, next level go ahead. So the regulatory mechanism is very important, otherwise there will be excess.
Right. Very rightly said. And now, Dr. Ruchi, we would like you to tell us something, a highlight about the amniotic fluid circulation in the fetus and in the mother. Dr. Ruchi is there.
Yes, can you hear me?
Yes.
Yeah.
Yes.
There are
Dr.
three
Varsha,
major-
ma'am, welcome. So you can take this
Yes.
question.
Yeah, thank you so much. Sorry, I was unable to join.
It's okay.
I'm really sorry, esteemed panelists. Thank you for coming over here and participating. Yeah, carry on, Dr. Preeti.
This question was to Dr. Ruchi Bhargav, but I get yes, Dr. Ruchi, would you like to take this question, please?
Yeah, so there are three major determinants influencing the amniotic fluid volume. One is transfer of solutes within and across the membrane. Then there is fetal regulation through swallowing and urine production. And then there is transplacental fluid movement. Now, if you look at the diagram, swallowing almost 500 to 1000 ml per ml. Lung fluid secretion is 340 ml, but half of it is reabsorbed by the system. Urine flow, we can take it as around 800 to 1000 ml. And there is intramembranous exchange of 200 to 500 ml, and about transmembranous is 10 ml. So roughly it is about 500 ml each hour that is leaving and entering the amniotic sac. Now, as Dr. Barindra said, gradually it is increasing up to 36 weeks, and then it starts decreasing at the rate of almost 8%. So that by term, we are, at about 40 weeks, we are left with around something around, say, 600 ml.
Correct.
So 22 to 28 weeks, more or less, the fluid volume remains stable. And then, after 36 weeks, it starts decreasing at the rate of about 8%.
Yes, absolutely correct.
I'm so happy Dr. Sushma Chawla, our guest of honor. Everybody is present over here till the end of the session. I'm really thankful and grateful. Carry on, Dr. Preeti.
Yeah, so very nicely said. And one thing I would like to point over here is, though we have this thing at 500 ml at 18 weeks, 800 ml at 34 weeks, and 600 ml at term, but we should also see one thing: if there is a diabetic patient and she is having less liquor, then though it might be in the normal range like of AFI, but suppose it is towards the lower side, then we should use our own clinical judgment also. Like if she's a diabetic and ideally she should have little more liquor if it's uncontrolled diabetic, and her liquor volume is already on a lesser side, one clinician should become more alert and have a better look that she might develop oligohydramnios. And oligohydramnios in these patients are in fact more severe than in any other patient. So amniotic fluid volume, which is mentioned here, is a rough guide, but clinical judgment is also very important. Whether, as Dr. Kuldeep rightly said, there should be an eyeballing at all the time, and we have to compare from our previous results also, because every baby is different. So next question goes to Dr. Dinesh. What is the function of amniotic fluid during pregnancy? Dr. Dinesh, can you hear me?
Dr. Dinesh, please unmute yourself.
Yeah, sorry, I just muted. We see that the amniotic fluid is covering all around the developing fetus, so it helps in development and growth and movement of the fetus. And when it is ingested, it helps in the development of the GI tract and also its maturation. And when it goes to the lungs, it helps in the development and growth of then developing the alveoli and all the terminal alveoli of the fetal lungs. And it, because of the water inside it, it protects from the external trauma, if any there, and it's uniformly all around. So it maintains uniform temperature. All the body part develops equally, and it also protects from the any infections like which has got antibacterial activity. And during the late stage, in the early stage of labor, it also helps in the dilation of the cervix, because we see that when there is a oligohydramnios patient, they mostly develop in a land up in cesarean section, and the fetus might have pulmonary hypoplasia, and all these complications are there in the oligohydramnios patient. So these are important function of the amniotic fluid.
Yes, correct. So amniotic fluid is required for the proper growth of all the organs of the baby. And if there is a oligohydramnios, then in the fetus, they not only, it has been seen that the amniotic bands and other things develop, pulmonary hypoplasia also develops. But also what we have seen is that if we delay the delivery of severe oligohydramnios patients for a very long time, even the intestinal circulation is affected. And in their neonatal period, they have more risk of developing neck or intestinal issues. So amniotic fluid circulation is very important for the baby's overall well-being. So next question is to Dr. Mini. What is the clinical importance of amniotic fluid? Dr. Mini?
Ma'am, I think she's busy in an emergency.
Okay. So I can, Dr. Dilpreet, would you like to take this question, please?
Yes, sure, Dr. Preeti. Clinical importance of amniotic fluid is that looking at the volume of amniotic fluid, we get a general idea about the fetal well-being. That is the most important thing. Is it oligo, poly, normal, everything as per period of gestation. And another thing is like to look for the fetal anatomy. It provides us a good window when we are doing ultrasound. We see like when the liquor is absent, it's very difficult to comment to rule out the anomalies. So that is another thing. And third is nowadays, in the era of genetic screening, after the biochemical markers, if required, amniocentesis is done, gives us, we do karyotyping culture, all those things, right? And lung maturity can be assessed, optical density, all those things from the liquor, we get a lot of things we come to know about the fetal well-being. And another is like previously also in the previous slide about the functions of amniotic fluid, we discussed about the antibacterial activity of this thing. So this is very important in the natural course of labor. If we are not doing ARM, not like the earlier when we were not following the active management for first stage of labor. So the natural time of membrane rupture is after the complete dilatation of cervix at the end of first stage. So immediately it flushes out all the bacteria. It prepares the vaginal canal for the delivery. Good aseptic atmosphere environment is provided for the fetus to come out. So all these, so this is very important clinically, amniotic fluid. I think most ignored topic, but this is very important. We always, whenever we are doing antenatal checkup, we look at the liquor in all the aspects.
Very nicely put, Dr. Dilpreet. Varsha ma'am, would you like to take the panel from here? Few questions.
Yeah, okay. If my internet allows me, I will continue. When to start assessing amniotic fluid index? Can you, it is very, very important, AFI. Dr. Jagdish, would you like to highlight on it? Yes, Dr. Jagdish, you have to unmute yourself.
Yes, ma'am. I'm sorry. Good evening, everybody. First of all, I would like to thank our organizers today, Dr. Vaisha and Dr. Preeti, for this beautiful opportunity. Dr. Vidhu and Dr. Gini from Ludhiana, along with here. I'm very humbled to be part of this panel where Dr. Kuldeep, Master of Masters, and Dr. Iqbal, our mentor and source of inspiration in Ludhiana, is here. And coming on to the question, assessing AFI, clinically, we are all taught in our medical school that yes, subjectively, you can always assess amniotic fluid through palpation, through your fundal grips and all. But as far as objective assessment is concerned, ultrasound is the key. Ultrasound is the key. And the assessment of amniotic fluid through ultrasound, it has been already described very well in today's lecture by Dr. Kuldeep. Sir, salute to you. Everything has been answered by you. And I will only add up that it can be deepest vertical pocket or amniotic fluid index, but it is always the operator friendly modality. It is how you measure it. For example, let us start that by 20 weeks you are able to have a good assessment of amniotic fluid index, but for 4-quadrant at 20 weeks it's very difficult. How do you assess the limitation of one pocket? They are all intermingled. So we are not treating the reports over here. We are treating a patient. We are treating some condition over here. And so it all depends upon the reporting, how we do it, as very beautifully put in by Dr. Kuldeep. And I'll complete this answer by saying that yes, there are modalities. The ultrasound is the modality. Best is to start by 20 weeks, and it's mandatory. Like this, it's a guidelines everywhere that every sonography assessment has to include amniotic fluid assessment. So
Absolutely, sir. Thank you so much for this detailed and elaborate answer. Deep vertical pocket is the most important, and ultrasound to assess the amniotic fluid index. So next question is for Dr. Shail Kaur. How do we define as oligohydramnios or polyhydramnios? Though we have witnessed the fantastic talk by Dr. Murlidhar Pai, but I would like you to elaborate. Dr. Shail Kaur, the beautiful girl, can you elaborate a little bit?
Thank you, ma'am. Actually, you're very right. The previous speakers have made it very clear that if we're taking an amniotic fluid index, we have to either see whether the AFI is less than 5 for an oligohydramnios or more than 25 to determine as a polyhydramnios, with further determination into mild, severe, and mild, moderate, or severe polyhydramnios. And if we look at vertical pockets, we would look at a pocket of 2 centimeters for determining oligo, or 8 for our polyhydramnios. But most of it is actually subjective, and many studies actually say that an experienced sonologist can clinically assess, even without measuring, whether it seems to be adequate, because it really depends upon whether they're able to pick up the cord-free areas or not. And I think this has been covered in big detail already.
I think we should skip this question of polyhydramnios because Dr. Murlidhar Pai has already elaborated too much on it and in detail. So can we take another question, Dr. Virinder Kaur? What can all lead to polyhydramnios?
And may I add one thing?
You have to elaborate.
May I add one thing?
Sandhu?
Yes.
Okay.
Yes, sir very rightly said. Dr. Kuldeep told us this thing that it should be perpendicular to the floor, everything. But one thing for the gynecs, as we are doing ultrasound on our own, we shouldn't take the vertical pocket with horizontal depth if it is less than 1 centimeter. Thin pockets should not be considered for taking the vertical pockets.
Very good.
That's one thing I read while going through the slides.
Yes, absolutely right. It should be at least 2 centimeter in transverse diameter, and then only we should take the vertical pocket ideally. Yeah.
Yes, that's
true. Very nice, Dr. Dilpreet. Anything else you would like to add?
Okay. Yes, please
Dr.
go ahead, ma'am. If time permits,
Dr. Virinder Kaur, what can lead to polyhydramnios?
Yes, that has been beautifully elaborated by Dr. Pai. He has given all the causes of polyhydramnios, maternal causes, fetal causes, placental causes, infections. Like he said, 30 to 40% are idiopathic, not known. Then maternal causes mainly is diabetes mellitus, renal and cardiac causes, fetal anomalies. He has told so many fetal anomalies like gastro obstruction, primary and secondary. Primary like esophageal atresia, duodenal atresia, and secondary the pressure upon the GI tract, which hinders in the swallowing, like any masses in the neck, and tumors, this diaphragmatic hernia, and then twin-to-twin transfusion syndrome, then non-immune hydrops and immune hydrops, infections. Sir said that parvovirus infection, that is important, and placental angiomas, placental tumors. Although they are very rare, but they are one of the causes of polyhydramnios.
Yes, absolutely, absolutely.
And sir had elaborated a few of the syndromes which even we haven't heard of.
Yeah.
And sir had that only sonologist can elaborate.
So let us not go into detail of polyhydramnios. I think we will take next question. Dr. Seema Bhatti, what is the clinical presentation of polyhydramnios? Just elaborate it shortly. Right. So patient comes to us with breathlessness, and she is having a tense abdomen. The skin is stretched out. It has become thin, and the patient has edema, significant fetal edema. And preterm labor is well known, PROM, even the patient may present with cord prolapse. So when we palpate the patient, fetal parts are difficult to palpate. The fetal heart is very difficult to hear. You cannot make out the lie, the presenting part. So all these are the presentations of significant polyhydramnios. Okay, Dr. Ruchi Bhargava, what are the complications of polyhydramnios? Continuation with Dr.
They can be maternal as well as fetal complications. So if we are looking at the fetal complications, we have to keep in mind all the congenital malformations that can be associated with polyhydramnios, the aneuploidies, and also fetal malpresentation in labor. As rightly said, we can have sudden cord prolapse, we can have abruption, and of course, preterm labor and PPROM both. And from the maternal point of view, we have to keep in mind the atonic uterus and PPH.
Ma'am, you are mute. Ma'am, Dr. Varsha, ma'am, you are mute.
I'm sorry. Dr. Vidul or Dr. Preeti, you can take over the next question.
Right. So, Dr. Dinesh, what are the treatment options available for polyhydramnios? If you can briefly and quickly outline them.
Yeah, whenever polyhydramnios is diagnosed, the patient should be hospitalized for proper monitoring, because already we know the complication, and she should be given a bed rest properly so that she does not have the respiratory problems, which is very common after having polyhydramnios. And as already discussed, if 32 weeks, less than 32 weeks, we can give indomethacin for 48 hours, not more than 48 hours. Because the increased risk of interventricular hemorrhage, morbidity, periventricular leukomalacia, and necrotizing enterocolitis. And then we can, if required, if there is any respiratory distress of the mother or maternal discomfort, then we can go for amnio reduction, slow and more than up to 1 liter slowly in 1 to 2 hours.
Correct.
To relieve the
So if we take
let us take one case. Should I continue, Dr. Preeti?
Yes, ma'am. Yes,
primary with 38 weeks has AFI of 29 centimeter with no other obstetric high risk factors and normal sugars. Now, wants to know the timing and mode of delivery. She's worried about the baby. Want to know how frequently do sonography. Dr. Mini Bedi, can you highlight on the answer?
I think she's
Dr.
not
Bedi?
there. Dr. Mini Bedi is not there.
Anybody can take it. Then Dr. Dilpreet, would
Yes,
you like
yes,
to take it?
Yes, sure.
Because you look
AFI
more enthusiastic.
AFI 29, see, 25 to 29, this falls in mild polyhydramnios. And it has been very nicely covered in the talks that we may go till term. This is mild polyhydramnios. As it is clearly mentioned that there is no other complication. So then moderate is if AFI comes to 30 to 35. And severe polyhydramnios where AFI is more than 35, then we have to see patient must be having a lot of cardiorespiratory embarrassment and all those symptoms. Then we need to intervene early. But otherwise, we can go beyond 39 weeks in mild polyhydramnios.
Very good. Very good. Yes. So the quadrants are very important, and also the length 2 centimeter and all what we just discussed. Next.
And for making the diagnosis of oligohydramnios, deepest vertical pocket is more reliable than total AFI, because if we are calculating total AFI, then it leads to overdiagnosis of oligohydramnios.
What are the causes of oligohydramnios? Mini, she's not there. Ruchi, you can take Bhargava.
Yes. You can divide it into fetal causes, maternal causes, placental causes, iatrogenic causes, and there can be certain other causes. Fetal causes, there can be some abnormalities. You can have fetal growth retardation. Maternal causes, as we see in hypertensive disorders of pregnancy, we see in post-dated pregnancies, in some cases of diabetes, SLE, APLA, all diseases which are causing some kind of chronic hypoxia, they can lead to oligohydramnios. Placental causes, let's not forget the twin-to-twin transfusion syndrome and abruptio placentae. Iatrogenic causes will be sometimes patients taking ACE inhibitors and NSAIDs or in amniocentesis, and other causes would include PROM as well as idiopathic causes of oligohydramnios. A commonest, of course, acute, or you can divide it into acute and chronic. Acute would be where PROM has taken place, and other causes would come under the chronic conditions.
Yeah. What are the complications with oligohydramnios? Ma'am, I want to say something. Yes. Okay, ma'am, about oligohydramnios here in Faridkot Medical College, we get very many patients. I do not know, but I've worked in Ludhiana for about 20 years. The incidence is very high in this belt. I don't know whether it is because of the pesticides on the food products or whatever the reasons are.
Ma'am, overall incidence of oligo has increased, and what I personally feel, lots of viral diseases in COVID. During COVID time, we saw lots of cases of oligohydramnios, and recently, in last 1 month, since that virus is there all over North India, where everybody is coughing, patients are coming with severe oligohydramnios. If you have done a scan 2 weeks back, liquor and everything is okay. They come after 2 weeks, you see oligohydramnios. I'm sure most of the obstetricians here will agree with me.
Yes, Dr. Priti, I agree 100%. There are too many cases of oligohydramnios these days. Even last few days back, one patient came with ultrasound with AFI 7, and after 1 week, she came again with ultrasound, which showed nil liquor.
Correct.
Yeah, Dr. Virendra Kaur, very good inputs you have given us.
In our
and ma'am, the outcome is good. We have seen that outcome is good, especially in unexplained cases. You know, if you manage reasonably well, outcome is very good for the baby.
Yes, outcome is good, but I don't know what is the cause, but lot of
Correct. Absolutely correct. So, Dr. Jagjit, would you now elaborate the complications with oligohydramnios, please?
Yes, ma'am. Definitely, this the topic about complications of oligohydramnios. It has two components. Like we are shooting the messenger over here. Why oligohydramnios? So if one is treating the cause, why oligohydramnios? Then now when oligohydramnios is there, now what can it cause? So I'll be speaking about only firstly about why oligohydramnios happened, and now once it has occurred, it can lead to so many things like because of less amount of fluid, there can be pressure symptoms, pressure deformities. There can be amniotic fluid adhesion.
Sorry to interrupt, the internet looks to be disturbed.
Is it okay now?
Yeah, we can hear you. Yes.
Okay.
So we would like you to quickly elaborate.
Yeah, because of the less amount of fluid, there can be pressure deformities, there can be amniotic fluid adhesions, blends, amputation, and pressure deformities on the face, flat face, postural deformities, cord depression, hypoxia, all those kind, and there can be, because of less space available, there can be growth restriction, and moreover there can be eruption which can lead to preterm labor and fetal distress, and even death can occur because of oligohydramnios. That's what I have.
Yeah, an increased risk of increased risk of
yes. And we are always much worried about oligohydramnios at term, because we don't want to lose a baby which has attained term. So now here comes the very good question that at term, how to manage oligohydramnios. So we have a very good algorithm over there. We have to see why oligohydramnios and how.
Excuse me, can you hear me?
Yes, ma'am.
Yes.
Yes, ma'am, please. Okay, I continue. Because at term we don't want to lose a baby, so we have developed a nice algorithm that when at term, when to induce labor and when not to induce labor. So we have to go into steps of that, just like going into the consideration that we have to look whether the oligohydramnios is due to some congenital malformation or is it due to constitutional cause like hypertension. If oligohydramnios is only due to hypertension, okay, fine, induce labor. If not happening, go for a cesarean. So that is how we set up the things. It's a one-to-one basis case of the thing, and it's very difficult to. Yes.
Yeah.
Excuse me, my internet looks to be very, very unstable. So I think I will have to, I may or may not be able to join. But let me interrupt by saying that I am contesting for the post of Vice President, Foxy West Zone. So please vote for me, nominate me, guide me, and support me, because my internet is very, very unstable. I'm trying hard to reconnect again and again. So carry on, Dr. Preeti. Thank
all
you
the
so
best,
much.
all the best, all the best, ma'am.
Each and everybody
All
is
the
so
best,
important.
ma'am. We from Punjab, we will definitely support you. All the best. Please go ahead.
And our support with you, ma'am.
So much. Thank you so much.
Lovely to
All
have
the
you.
best, Dr. Varsha. We are with you.
Thank
Best
you
wishes,
for
ma'am.
your
We are
blessing
with
and
you.
support and well wishes.
Best
Thank you.
wishes, ma'am.
Carry on, Dr. Preeti.
So next question to Dr. Sher. What are the treatment options for the oligohydramnios?
The treatment options would actually depend, first of all, on what is the reason that we evaluate for the oligohydramnios. If it is because of PROM, then obviously the management would be different. And if we are able to rule out any congenital malformation, etc., that is a very important aspect. And if nothing else comes out and there is no associated FGR, it is just an isolated oligohydramnios, then probably just rest and adequate hydration therapy really makes a lot of effect. If it is difficult to find out the cause of oligohydramnios or to rule out the possibility of any anomalies, many people have even evaluated by giving amnio infusion so that you have a better pocket to find out anomalies, because anomalies are very frequently associated with the presence of oligohydramnios. Hydration really helps in patients with idiopathic oligohydramnios more than any FGR or any other cause. And obviously in PROM, it is a very temporary help. Lots of drugs have been used. We've given lots of arginine therapies. We've given sildenafil. Some studies show that they are helpful. Some studies have absolutely stopped giving sildenafil because of lots of perinatal mortalities that they noted. But overall, it is mostly, as we have discussed in the previous talks also, it is mostly monitoring and trying to take them as much as possible with on a tight rope, where you have to look at the mother also and the fetus also. Intensive fetal monitoring and delivery as soon as possible would definitely help.
Correct, Dr. Sher. Here I would like to add something called sildenafil. Sildenafil is one drug which has got lots of controversial reviews. As of today, all the guidelines they guide against using sildenafil, but having said that, lots of Indian research papers, and even I have personal experience of sildenafil, and I have found it to be very effective, and especially in cases of early onset oligohydramnios, like at 24 weeks, at 25 weeks, where anyway you are pushed to the wall. And if you give sildenafil, actually I have found very good results. The studies, there was one trial, the Strider trial, which had put sildenafil on hold. They found increased incidence of pulmonary arterial hypertension in the neonates. But at the same time, it is surprising that for the treatment of pulmonary arterial hypertension, sildenafil is used. Secondly, if you go very, very minutely in that Strider trial, you'll see only at 2 places it was halted, in Denmark and in France. But at other places, the results were that they cannot conclude that pulmonary arterial hypertension is because of sildenafil or because of underlying cause of oligohydramnios. So here is what I wanted to say, that it's high time that we Indians should publish their own studies and not just stop using medications or anything just on the basis of what the foreign trials tell, because we have a much bigger number of patients and we all can club our studies together and present them. So it is still the take-home messages that most of the guidelines, they say that we should not use sildenafil.
Yes, because actually, if you see, even in most of our patients, even rest, providing adequate rest and giving a proper hydration therapy actually makes a difference. And this is sometimes some things we very frequently omit advising to our patients. And if we are able to put it across, then probably these things help, because any patient who's being given sildenafil or any other medicine is always advised rest and hydration at the same time.
It has to be given, the rest, hydration, and rest, especially in left lateral position, because in between there was a time when it was said that any position is okay. But now again, the studies have shown left lateral position help. So these are the basic: left lateral position, rest, hydration,
nutrition, correction of anemia, all those common things in our scenario.
Undernourishment. Ma'am, coconut water has shown good results. We have seen in our patients.
Yes.
And fruits and vegetables with a lot of water content, like melons, bottle gourd, and all that. Also.
Right. So now next we go to our
Rishi, I have a comment to make.
Yeah.
I have a question to ask.
Yeah. Please go ahead.
Infusion also helps.
Yes, I was coming to that. What about the amino acids, which are given left and right?
Amino acids, they are given, and we have found that high protein, it does help, but in the most of the guidelines, they say it does not help, the recent guidelines. But then most of our women anyway are malnourished. So giving them protein diet and arginine sachet may help, may not help. But the guidelines as of now say they do not help.
And as Dr. Preeti said, we don't have our own data.
I'm talking about the amino acid infusions.
That is not recommended. It's not FDA approved.
This is a carry-home message. This is a carry-home message. It is really being misused, overused. So it is a carry-home message. Doesn't make any difference. It is just a false hope to the patient.
Correct. And amino infusions actually has led to anaphylactic reactions in few women. So one should be very careful if still you want to use it. But guidelines, they say, and we have also seen it does not help much. So now, Dr. Vineet, you are there, so might like to comment on ecogenic amniotic fluid, please.
I think you guys go ahead.
So anybody would like to take this question? It has been discussed.
I don't expect everyone. I just had coffee to be up.
All right.
Go ahead.
So, the last question.
Nicely covered by Dr. Kuldeep, actually.
Correct. So as we are getting late, I will just put few take-home messages. We should measure AFI after 16 weeks. Don't report subjectively. Use your own brains as well. Suspected polyhydramnios, measure 4 quadrant. And when you are really pushed to the wall and there is oligohydramnios, then single deepest vertical pocket really helps rather than moving to AFI. Now look out for the basic cause, as Dr. Alka ma'am said rightly, that the indication for cesarean or induction is not oligohydramnios. You have to find the basic cause, what led to it, and higher the polyhydramnios, higher the chances of underlying fetal abnormality. Always take a consent of esophageal ectasia or TOF, because that cannot be diagnosed prenatally. And isolated poly or oligo in mild forms doesn't alter obstetrical outcome management. I would like to thank all the esteemed panelists for staying back for such long hours.
One comment again.
So wonderful.
Preeti, one comment again.
Correct. Okay, yeah, please.
Yeah. Most of the time we have seen that when we don't do the ultrasound and the patient comes with these are all the practical things I'm talking. And patient comes with a report from a radiologist that the Leica is decreased, and they have already counseled, he go for an immediate cesarean section, and they have really made up their mind, and it is very difficult to do a counseling right then.
It is a very practical thing we all face. So anyone? Dilpreet, Shail? The beautiful sister-in-laws are here.
The baby is already compromised. I think you have to tell them good and bad things. A baby is already under stress with oligohydramnios. So in case we have to give the good prognosis with a good neonatologist or NICU, I think cesarean section remains the ideal, because that baby may not be able to take up the labor pains. That's it. This is what
So
I
would like to thank you, ma'am, for the inputs.
I just
and
want
I
to
would
make
like
a point.
to conclude the panel
I just want
now.
to make a point that don't let the radiologist decide about the cesarean section.
Absolutely. We should stick to our own fields.
Yes.
So very nice point. And thank you, everyone. And we conclude the session. Thank you for the SHIELD team. Thank you to Varsha ma'am. And thank you to all the esteemed speakers and panelists and all the participants. Thank you very much.